Cholesteatoma surgery. The variation in technique in cholesteatoma surgery results from each surgeon's judgment whether to retain or remove certain structures housed within the temporal bone in order to facilitate the removal of cholesteatoma. This typically involves some form of mastoidectomy, which may or may not involve removing the posterior ear canal wall and the ossicles. Removal of the canal wall facilitates the complete clearance of cholesteatoma from the temporal bone in three ways. It removes a large surface onto which cholesteatoma may be adherent. It removes a barrier behind which the cholesteatoma may be hidden. It removes an impediment to the introduction of instruments used for the removal of cholesteatoma. Thus, removal of the canal wall provides one of the most effective strategies for achieving the primary aim of cholesteatoma surgery, the complete removal of cholesteatoma. However, there is a trade-off, since the functional impact of canal wall removal is also important. The removal of the ear canal wall results in a space, the mastoid cavity, which is less likely than the original ear canal to resist infection. Exposure of the ossicles, which may allow the subsequent formation of a new cholesteatoma deep to the ossicles. To prevent this, these ossicles must be removed, which may diminish the patient's hearing. The formation of a mastoid cavity by removal of the canal wall is the simplest and most effective procedure for facilitating the removal of cholesteatoma, but may bestow the most lasting infirmity due to loss of ear function upon the patient treated in this way. The following strategies are employed to mitigate the effects of canal wall removal. Careful design and construction of the mastoid cavity. This is essential for the health and integrity of the protective sheet of migrating, keratizing epithelium which lines the distorted ear canal. This requires the surgeon to saucerize the cavity. A high facial ridge and an inappropriately small cartilaginous meatus are obstructions to epithelial migration and are particularly high risk factors for failure of the self-cleaning mechanism of the external ear. Partial obliteration of the mastoid cavity. This can be performed using a wide range of materials. Many of these resorb time, which means that the long-term results of such surgery are poorer than the short-term results. Reconstruction of the ear canal wall. Canal wall reconstruction has been performed using ear canal skin alone, fascia, cartilage, titanium, as well as by replacing the original intact wall. If the reconstruction is poorly performed, it may result in a high rate of recurrent cholesteatoma. 11. Preservation of the ear canal wall. If poorly performed, it may result in a high rate of both residual and recurrent cholesteatoma. Reconstruction of the chain of hearing bones. Clearly, preservation and restoration of ear function at the same time as total removal of cholesteatoma requires a high level of surgical expertise. Medicine by Alexandros G. Sfakianakis, Anapaphysios 5 Agios Nikolaos 72100 Crete, Greece, 00306932607174003028410261882, alsfakia@gmail.com.